Hello students, today we are going to talk about a very important concept in biopharmaceutics and pharmacokinetics, that is protein-drug binding and factors that affects it. Protein binding plays a huge role in how much drug is free in the body and how much is bound. Remember, only the free drug is pharmacologically active. The bound drug acts like a reservoir, slowly releasing drug into circulation. So, understanding the factors that affect protein binding is key to predicting a drug action, drug interactions, and even toxicities. Let's discuss main factors. According to notes, there are four main categories. First one is drug related factors. Second one is protein tissue related factors. Third one is drug interactions. Fourth one is patient related factors. We'll go through each one step by step. First one is drug related factors. Now let's first look at the factors related to the drug itself. Physicochemical properties of the drug like lipophilicity, stereoselectivity, nature of drug, concentration of drug, affinity of drug for plasma and tissue. Okay. Then second one we have protein tissue related factors. Physicochemical nature of the protein, concentration of available protein, binding sites on protein. Third one we have drug interactions, displacement interactions, competition between drugs and endogenous substances, allosteric alterations in protein, and fourth one we have patient related factors, age, pregnancy, medical conditions. If you remember these headings, you can write down in detail in exam. Let's discuss physicochemical properties of drug in drug related factors. So this means physicochemical properties of drug means the drug's own chemical and physical nature, like whether it's lipophilic, hydrophilic, acidic, basic, or neutral. First one we have lipophilic. Highly lipophilic drugs bind strongly to proteins. Example, uh, cloxacillin is highly lipophilic and hence extensively bound to protein. So the more lipophilic, the higher the protein binding. Next one we have the stereoselectivity. Drugs that exist as enantiomers often show stereoselective binding. Acidic drugs like warfarin and ibuprofen bind more to albumin, while the basic drugs like chloroquine and verapamil show different affinity patterns. Moving on to nature of the drug is the type. It means the type of drug determines which protein it prefers. Example, acidic drugs like penicillin, sulfonamides bind mainly to albumin. Okay. Then basic drugs like imipramine, propanolol bind to AAG, alpha-1 acid glycoprotein. Neutral drugs like cyclosporin A bind more to lipoproteins. Concentration of drug in body. Each drug has a fixed percentage of binding. Once the binding sites are saturated, excess drug remains free in plasma. Then we have affinity of drug for a particular plasma tissue protein. Some drugs prefer specific proteins or tissues, like digoxin binds strongly to cardiac muscles, while the lidocaine has more higher affinity for AAG than albumin. Now let's talk about the proteins themselves. First one is physicochemical nature of proteins. The structure and charge of proteins influence drug binding. For example, lipoproteins and adipose tissue tend to bind lipophilic drugs. Okay. Then we have the concentration of protein here. The more proteins present, the higher the drug binding. Albumin is the most abundant plasma protein, binds mainly to acidic drugs. Any increase or decrease in plasma proteins due to diseases or pregnancy will directly affect its binding, protein drug binding. Now we have binding sites on proteins. Here you can take the example of albumin. Albumin has multiple binding sites. Okay, large number of binding sites albumin has, allowing it to bind many different drugs. Okay, it can bind with many different drugs at once. The third one is drug interactions. Now comes a very practical factor, interactions between drugs and other molecules. First one is displacement interactions. If two drugs compete for the same binding site, one can displace the other. Okay. Example, warfarin displaced by phenylbutazone increases free warfarin can cause toxicity. You can see in the diagram that we have a protein and its binding site is here, and we have two drugs A and B. A drug represents as warfarin and phenylbutazone is B drug. So first of all, what happens? Warfarin comes and binds to its binding site on protein. Then it looks like this. After some time, the same affinity drug comes to bind on this binding site on protein, which is phenylbutazone. So it comes here and replace it, and it gets bind to this protein. So what happens? Now the B drug is bound to protein and A drug drug concentration in plasma increases because it has nowhere to get bind. So what happens after certain point? It the patient might feel toxicity. Toxicity can occur. Now let's see the competition between endogenous substances. Natural substances like fatty acids and bilirubin also compete with drugs for albumin binding. This can alter the amount of free drug available. Next is allosteric alterations. Some drugs or their metabolites cause structural changes in proteins, which altering their binding capacity. So any structural changes in proteins also reflects its binding capacity with others. Finally, let's look at patient-related factors. First one here is age. Under age, we have neonates, infants, elderly. Neonates, they have low albumin content. So, more free drug concentration because drug has nothing to bind with. So, if more free drug concentration, it also reflects risks of toxicity increases. Then, talking about the infants. Infants. In infants, both albumin and AAG content are very low. So they need higher doses of drugs like digoxin compared to adults. Then we have elderly. In elderly, low albumin levels are there. So increases free acidic drugs. Also they have high AAG. So it decreases free basic drugs binding. Next is pregnancy. So during pregnancy, albumin level decreases. So less binding of acidic drugs is seen. Next we have medical conditions. Certain diseases alter protein levels like renal failure. In renal failure, albumin levels decreases. So less binding of acidic drugs is seen. Then second one is hepatic failure. During hepatic failure, albumin levels it decreases. Okay, so synthesis decreases here. So reduced binding. Then we have surgery, burns, trauma, etc. So here AAG levels increases, so more binding of basic drugs is seen. So the main factors affecting protein drug binding were: first one, drug properties; second one, protein tissue properties; third one, interactions between other drugs or substances; fourth one, patient specific factors like age, pregnancy, or any diseases. So in conclusion, protein drug binding is a dynamic process and it decides how much drug is free and versus how much drug is bound. Then it also decides the duration of action of drug. Also it decides that drug interactions or risks of drug interactions. So always remember, only the free drug is active. So any change in binding can greatly affect the clinical response. Thanks for watching this video.